really glad to have Michelle Ramirez here. Michelle is a physical therapist by training. She is a specifically board certified as a clinical orthopedic clinical specialist. And she is currently a PhD student in population health sciences at Duke University. A number of us have had the privilege of working with Michelle on various projects, and she's doing some super work. And so I'm looking forward to having her talk with us more about that today. And she's going to be talking to us about mind matters, characterizing and predicting psychological distress phenotypes among patients undergoing joint arthroplasty. All right, Michelle, all yours.
Great. Thank you so much, Dr. Allen, for that introduction. It's really great to be here. And I'd also like to thank UNC CCCR for the invitation and the Thurston Arthritis Research Center. So as Dr. Allen mentioned, I'm clinically trained as a physical therapist and currently pursuing my PhD in population health sciences at Duke. And I'm really excited to share two specific studies related to some of my dissertation work today with you guys. So I have no relevant financial or related relationships to disclose, but I think it's really important for me to acknowledge some research and training funding because without the support from these groups, my research and training would not be possible. So I just wanted to acknowledge them as well. So these are the objectives for today. So I'll begin by introducing psychological distress as it relates to osteoarthritis and total joint arthroplasty, and really honing into the relevance of these characteristics to patient-reported outcomes. I'll also be sharing two studies related to my dissertation. The first study will focus on characterizing and describing the transition of psychological distress phenotypes in a cohort of patients undergoing arthroplasty. And the second study involved developing and evaluating machine learning models for predicting a high psychological distress phenotype after joint replacement. And then lastly, we'll have plenty of time at the end for discussion and questions. So most of you are probably fairly familiar with the more common constructs of psychological distress, such as anxiety or depression. You probably see those measured quite a bit in the clinic. However, there's also these other less commonly recognized cognitive and behavioral characteristics that also fall under this umbrella. And these can include pain catastrophizing, fear avoidance beliefs, pain coping, other characteristics such as kinesiophobia, anger, chronic pain acceptance, and self-efficacy. So all of these characteristics have demonstrated associations with outcomes of various osteoarthritis interventions and also outcomes following arthroplasty. But what I really gained and learned as a clinician while treating patients is that although these individual constructs of psychological characteristics were important, I often found that patients presented to me with various patterns of these characteristics and not necessarily in isolation, but in combination together. And so I became curious at this time and as to ways that I could tailor my interventions to target these various patterns versus just targeting specific individual constructs individually. So psychological distress can amplify pain perception, it can increase disability, diminish patients' quality of life. These are things that, we kind of all generally have a good idea about. It can affect patients' ability to participate in social activities that are meaningful to them, perform activities of daily living, and their ability to work. And distress itself may actually have a larger influence on pain intensity and disability when compared to other traditional impairments that we might measure, especially from a physical therapy perspective, like range of motion or strength, or even neuromotor coordination. And there are also these other characteristics such as self-efficacy and pain coping. These can actually contribute to favorable psychological and functional outcomes. So that's really important and key as well. And understanding which patient subgroups would benefit from behavioral health referral or targeted treatment approaches is really critical for reducing costs, providing optimal care, and improving overall outcomes for patients. So per year, approximately 4 million US patients are projected to undergo total knee or hip arthroplasty by 2030. And about 15% of these patients will fail to achieve clinically important differences up to 12 months after surgery. And what I gathered was there's really limited evidence that describes how these phenotypes and psychological characteristics might progress from before surgery to after surgery in patients undergoing joint replacement. So you guys are probably familiar with Dr. Trevor Lentz. He's with us here at Duke, and he performed a study in 2020 demonstrating that 75% of patients with osteoarthritis present with psychological profiles that can be characterized by negative mood, negative coping, and low self-efficacy. And really, these psychological factors are not completely addressed through surgery alone. There was a systematic review of patient satisfaction after total knee arthroplasty, and the most common preoperative predictor of dissatisfaction with surgery was preoperative anxiety and depression. And preliminary studies have also suggested that these risk classifications have the potential to change over time over the course of treatment. So really understanding if psychological characteristics remain stable or how they change is really important and can add some value to the knowledge that we already have from baseline assessments. So the impact of psychological distress on patient-reported outcomes is also fairly well known and out in the literature. This is just an example of a prospective multi-center study involving 282 patients undergoing hip or knee arthroplasty. And this study particularly observed that patients with preoperative anxiety and depressive symptoms, they reported worse PROs 3 and 12 months after surgery and were less satisfied than those without such symptoms. This was just another systematic review by Visors et al. That found strong evidence that patients with the isolated construct of pain catastrophizing reported increased pain after surgery, and that 1 year after total knee arthroplasty, um, lower preoperative mental health was strongly associated with decreased physical function and also increased pain. So when I was searching the literature, and even as a clinician, when I was looking for some further guidance on, what do the clinical practice guidelines recommend? How should I approach my treatment with these patients? Several of the guidelines recommend adjunctive treatments such as CBT, so cognitive behavioral therapy for patients that exhibit behavioral health profiles associated with distress. Um, in another review, 3 guidelines recommended cognitive behavioral therapy for certain patient subgroups. And there was one guideline that advised against its use except in individuals with widespread pain or depression. So despite these various recommendations, there's a little bit of a gap in terms of how to identify these high risk patients using more of a multi-dimensional approach versus a singular construct approach. So specifically in the studies that I'll be sharing with you today, we use the 10-item version of the OSPRO Yellow Flag tool. This is a quick and easy tool that can estimate patient scores on 11 full-length psychological questionnaires that fall under these 3 different domains. So negative mood, negative coping, and positive affect and coping. And then based on the score estimates, the OSPRO yellow flag determines whether a yellow flag is present or absent for each of these psychological constructs. And this classification allows for a total of 0, which would be kind of considered no distress, to 11, which is highest distress possible yellow flags. And here you can see the constructs and some of the associated questionnaires, such as the PHQ-9, which is probably pretty familiar to most of you. Also the PCS, which is the pain catastrophizing scale, and also the Tampa scale for kinesiophobia. Those are just some of the most common ones that you might see in the clinic. So phenotyping patients is a key strategy for improving risk stratification and kind of approaching care from this personalized um, care perspective. So 4 different phenotypes have been previously described by Dr. Lentz in a non-operative cohort of patients with osteoarthritis. They've also been characterized in a low back pain cohort and another cohort of patients with non-arthritic related hip pain. But these phenotypes have not been characterized in a cohort of patients undergoing arthroplasty or has their transition over time been described. So the overall big picture question that I was interested in was how can we improve the understanding of psychological distress in patients undergoing arthroplasty to inform targeted screening and risk stratification, improve tailored treatment interventions, and also have the potential to predict future distress after surgery. So to help answer this question, the first study I'll be sharing with you guys is aimed at characterizing and evaluating the transition of psychological distress phenotypes among patients undergoing joint arthroplasty. The primary objective of this study was to characterize these phenotypes. The secondary objective was to describe the transition of these phenotypes from before surgery to after surgery. And then lastly, we wanted to compare patient demographics and patient-reported outcomes across these phenotypes to see if there was any differences with respect to those characteristics across the different subgroups. In terms of the impact, we felt that characterizing change in psychological distress phenotypes could help clinicians develop individual treatment pathways that are personalized to specific patient characteristics. And this has the potential to improve the efficiency and effectiveness of treatment and outcomes following surgery. So this was a retrospective observational study of patients undergoing arthroplasty at Duke from 2018 to 2024. Patients were excluded from the study if they were under the age of 18, had incomplete ostro yellow flag measures, or underwent bilateral or revision arthroplasty. The primary measure was the OSPRO yellow flag tool, and the primary outcome of interest was the patient's postoperative psychological distress phenotype. The PROs and patient variables included, we collect these, the standard of care at Duke, which is the PROMIS CAT physical function and pain interference measures, the numeric pain rating scale, and other various patient demographics. And the phenotypes themselves, we characterize these using latent class analysis and OSPRO yellow flag measures within a 6-month window preoperatively and a 3 to 12-month window after surgery. And descriptive statistics were used to describe the transitions in the phenotypes using a transition matrix and a Sankey diagram. And then lastly, we used bivariate analysis to compare demographics and PROs across the different subgroups of phenotypes. So regarding the results, this is just a summary of our patient demographics. We had 553 patients that met the eligibility criteria. The average age was about 66 years old. They were predominantly female and white. Almost half the patients were classified as obese. And not surprisingly, total knee arthroplasty was the most common joint site, and followed by hip and then shoulder. And the average Ilix-Hauser comorbidity score was about 3, and most patients were discharged home after surgery. So using the latent class analysis approach, we identified 5 distinct phenotypes before and after surgery. The identified phenotypes included a low distress subgroup, a subgroup of patients characterized by poor pain coping, another subgroup characterized by low self-efficacy and acceptance, a subgroup characterized by low self-efficacy and poor pain coping, and then lastly, a high distress phenotype. When looking at whether patient characteristics differed between the different phenotype subgroups, our study didn't find or reveal any statistically significant differences in postoperative phenotypes based on age categories, sex, race, ethnicity, discharge location, patient's length of stay, or surgical site. But we did observe significant differences for age as a continuous variable, BMI category, pre-op anxiety, pre-op depression, current tobacco use, ADI national rank, and number of comorbidities. And for the post hoc analysis that we did with these variables, the ADI national rank differed between, there was a higher ADI national rank between the subgroups of um, low self-efficacy and poor pain coping, and also the poor pain coping phenotypes. Those two phenotypes demonstrated the area deprivation index scores that were higher in those two groups. For the rest of them, I believe higher values of the rest of the groups were associated with the high distress phenotype, and that differed between the other groups. So the poor pain coping phenotype had the lowest mean age. The high distress phenotype demonstrated higher prevalence of obesity and increased comorbidity burden. And also, not surprisingly, the low distress phenotype demonstrated lowest comorbidity burden, the highest proportion of patients classified as having healthy or mild systemic disease. So for our third aim, we wanted to describe the transition of these phenotypes before and after surgery. So we observed that 63% of patients who were initially classified as high distress before surgery, they remained in high distress after surgery within the 3 to 12 months postoperatively. And then we also observed that 9% of patients who did not have preoperative high distress, they transitioned to high distress after surgery. And among those with preoperative low distress, 56% maintained low distress after surgery. So if you had preoperative low distress, 56% of those patients stayed in that subgroup. The others transitioned to other subgroups after surgery. And something that we didn't expect to find that we found interesting was that apart from the preoperative high distress phenotype, the largest transition to high distress after surgery came from the low self-efficacy and poor pain coping phenotype. And this suggests that patients presenting preoperatively with either high distress or deficits in self-efficacy and poor pain coping may actually benefit from, they may actually have an increased risk for persistent or worsening psychological distress after surgery. So this is just an illustration of the Sankey diagram that demonstrates the transition of the phenotypes pre and post. We observed that the psychological phenotypes, we got a better appreciation of how dynamic they are rather than being fixed. And considered, and we want to make sure we try to understand that these phenotypes they have possibility to change over time, and that baseline measures may not necessarily demonstrate the full picture of how patients transition after surgical intervention. And for our last aim, we also wanted to compare PROs across the postoperative phenotype. So before surgery, we observed that the low distress phenotype had significantly higher PROMIS physical function scores. They also had lower PROMIS pain interference scores than the other phenotypes. And postoperatively, those characterized by low distress phenotype reported significantly lower pain scores compared to the high distress subgroup and significantly higher PROMIS physical function scores. And surprisingly, the preoperative pain scores did not differ by phenotype. So the identification of these distinct psychological distress phenotypes and the differences that we recognized in PROs has some important clinical implications. So this flow diagram is just an example of how these phenotypes, classifying these patients by these phenotypes preoperatively um, with potentially matched intervention strategies. So for example, patients with low preoperative distress phenotype may benefit from emphasis on standard of care or reinforcement of osteoarthritis education and self-management. However, those with low self-efficacy and poor pain coping perhaps would benefit from treatment emphasis on motivational interviewing, value-based goal setting, rest activity cycling, or graded activity. And likewise, those characterized as high distress before surgery may benefit from a multidisciplinary approach, such as potential for behavioral health referrals, psychologically informed physical therapy, and other cognitive and behavioral strategies. So in conclusion, for this study, we identified 5 distinct psychological distress phenotypes. A new onset of high psychological distress occurred in 9% of the cohort after surgery. Patients with preoperative high distress and those with low self-efficacy and poor pain coping phenotypes more frequently persisted or transitioned into high distress after surgery. And they also had higher pain interference, pain scores, and lower physical function compared to the other subgroups. And these phenotypes present opportunities for preoperative targeted screening, which can enable risk stratification and psychologically tailored interventions. And this study is currently under review with Arthritis Care and Research. So after we completed this first study, we wanted to see if there was a way that we can predict a high postoperative psychological distress phenotype using machine learning methods. And so that was the focus of this second study that I'll be sharing with you here in the next following slides. So this second study was informed by a modified fear avoidance model that we integrated with the theory of behavioral change through Bandura's self-efficacy model. So for example, the patient undergoes, if you look at the center of the 2 cycles here, the patient undergoes surgery, and this can result in pain catastrophizing. This can lead to pain-related fear and ultimately disability and depression, which can further exacerbate the pain experience and kind of facilitate the left-hand side of this of the cycle here. On the contrary, there's characteristics such as self-efficacy and active coping can facilitate the confrontation of pain and can lead to positive outcomes. So that right-hand side of the cycle. So the idea is that by identifying patients before surgery who may be at increased risk for high distress and intervening preoperatively, we theorize that it may be possible to facilitate the patient to a more favorable pathway. So that right-hand side of the circle here before surgery, and thereby improve a patient's probability for achieving a meaningful postoperative outcome. So the use of machine learning is demonstrating promise and providing and improving quality of care, especially in the setting of arthroplasty. Predicting postoperative psychological distress may help to inform targeted interventions before surgery to improve outcomes. In a systematic review, they found that less than 35% of models predicting patient outcomes, specifically after total knee arthroplasty, had a AUC that was excellent or outstanding. So further research into the development of models that are meaningful and can provide clinical utility are needed to maximize their potential for use in clinical practice. So the primary objectives of this second study was to develop a machine learning algorithm predicting psychological distress 3 and 12 months after surgery. And our secondary aim was to develop an interactive web-based risk calculator to facilitate clinical implementation of our findings. So for this study, we used the same cohort and phenotypes identified in study 1. Our primary outcome was patients characterized as a high psychological distress phenotype after surgery. And features included preoperative PROMIS physical function, pain interference, the numeric pain rating scale, and various other patient characteristics. The primary analysis involved developing and comparing predictive performance of 4 different learning models. And specifically, we looked at extreme gradient boosting, ElasticNet, random forest, and the superlearner ensemble models to predict psychological distress 3 and 12 months after surgery. And the area under the curve was used as the main performance metric. And we also compared accuracy, sensitivity, specificity, and Breyer score. And we assessed calibration and also performed decision curve analysis for the best performing model. And to evaluate feature explanations, we used the Shapley additive explanation values, or what you might hear as called SHAP values. And based on the most important features, we created an interactive web-based risk prediction calculator that I'll be sharing with you in a few slides. So this is a table that provides just a brief description of the different models and their strengths and limitations. So the extreme gradient boosting and random forest, these are tree-based models. They use a decision structure to make predictions. They tend to have a little bit higher accuracy and handle interactions well between variables, but they can be computationally complex and a little bit less interpretable than some of the other models. The ElasticNet, this is a machine learning method used to make predictions when you have many features and you want to avoid overfitting. It finds a pretty good balance between keeping important features and shrinking those that might be less useful within the model. In this superlearner model, it's an ensemble machine learning approach that combines multiple predictive algorithms to generate a final model. So in our case, it combined the other 3, the extreme gradient boosting, random forest, and ElasticNet. To generate a final model that tends to have superior performance. The downfall to superlearners is that they can be difficult to implement in real-world clinical practice just because they're pretty complex in their nature and they rely on combining multiple algorithms together. So this is a summary of our methods. I won't go through all of these, but I wanted to just share for those that were interested. We did split the data into a 70-30 split, stratified by the outcome. We used bag imputation for missing data, and upsampling for the minority class was performed to make sure that there was equal distribution of the outcome within the training and the testing sets. And model tuning involved 5-fold cross-validation, and we use UNC J statistic for model tuning. So overall, a total of 553 patients met eligibility criteria and were included in the analysis. 386 were split into the training cohort and 167 into the testing cohort. Give me 1 second, I'm having some challenges here. And so I apologize for that. And the overall, the median age was 67 years old, and 64.4% were female. Anxiety and depression were reported in 107 and 108 patients respectively. Post-operatively, 19% of patients were classified in that high distress phenotype. And the median OSPRO yellow flag count preoperatively was 5, with a median pain score of 4. So this next table just demonstrates the characteristics of each of the cohorts after the splitting. So there was no statistical significant difference found between the two different cohorts, and this indicated balance between the two groups. And during pre-processing, the random forest model identified our top 10 features. So that's what this table shows here. This included the OSPRO yellow flag count, OSPRO summary score, BMI, patient's preoperative pain score, their age at surgery, the PROMIS physical function and pain interference scores before surgery, the Elix-Hauser comorbidity score, and presence of preoperative depression and female sex. So when looking at our model performance, the elastic net and superlearner models achieved the highest discriminative performance in the testing set, each with a AUC of about 0.82. The superlearner model demonstrated slightly higher accuracy and sensitivity compared to the elastic net. However, the elastic net had superior specificity and overall is easier to interpret compared to the superlearner. The logistic regression did fairly well. It was our third best performing model, followed by the extreme gradient boosting model. And overall, the ElasticNet model was selected for its strong performance, its interpretability, and also clinical applicability. So this was our ROC curve of the ElasticNet model, and also the calibration plot. The calibration plot demonstrated moderate calibration across the range of predicted probabilities. The model slightly underpredicted risk in a little bit of that moderate probability range. So you can see that here on the calibration plot. The Sharpe value analysis for our ElasticNet model indicated that the most influential predictors were the Austrial flag count and summary score, so that wasn't too surprising, with higher scores indicating greater risk for postoperative distress. And others included greater comorbidity burden, the presence of preoperative depression, reduced preoperative physical function, and elevated preoperative pain interference. Younger age and female sex also showed meaningful influence on risk for postoperative high distress after surgery. So with the decision curve analysis, this is a method used to evaluate the clinical usefulness of predictive models. So one of the strengths of using the decision curve analysis is that it's patient-centered and it focuses on the clinical utility of the model rather than just the predicted discrimination, which you would get from the area under the curve. This decision curve shows how useful each model is for making clinical decisions across different risk thresholds. So what we really wanted to determine was whether using the elastic net model versus using a logistic regression model only using the OSPRO yellow flag count. We wanted to see if there was actual clinical utility in using one versus the other. So the blue line here represents our ElasticNet model, and the red dash line represents the logistic regression model using only the OSPRO yellow flag count. This was chosen because it was our strongest predictor. The y-axis shows what they would call the net benefit, which combines true positives and false positives to show how helpful the model is. The x-axis shows the threshold probability, so you can see that there. And this is a cutoff at which a clinician might decide to intervene. So for example, the cutoff that they would refer a patient for behavioral support. The lines labeled all and none, these are just reference strategies indicating the benefit of referring all patients or no patient. And the cost benefit ratio, which is what you see all the way at the bottom. On the left-hand side, so if you see where it says 1 to 4, This means that you're willing to accept 4 unnecessary referrals to correctly identify one true case. So in general, lower thresholds indicate a more conservative approach and you want to catch every possible high-risk patient. So basically, it would be you're okay with over referral, even if that means that you have more false positives. And then the higher thresholds, which are those thresholds to the right, so like the 3 to 2, the 4 to 1, this means you prefer fewer unnecessary referrals, even if you miss some true positives. So overall, the elastic net model had higher net benefit than the OSPRO yellow flag count alone, especially between that zero 0.4 to 0.65 threshold probability. And this suggests that using the elastic net model could potentially lead to better decisions about who to refer by identifying more true high distress cases while avoiding unnecessary referrals, especially within those moderate threshold probabilities between zero 0.4 and 0.65. So one of the key benefits of predictive model development is number one, right, is to develop these types of models to try and improve patient care and outcomes, but also to improve clinical decision making. So using our ElasticNet model, we developed a Shiny app risk calculator. Now, just as a disclosure, we have not externally validated these models. So this is just for reference and just to have an idea, an example of what this potentially could look like. So I included the QR code here to the Shiny app for those of you who might like to play with it a little bit. But again, it's not meant to be used for clinical practice at this time. But the app allows users to input a patient's preoperative characteristics and various outcome measures. And then by clicking the predict, which is at the bottom of the screen, the app generates personalized estimates of the probability of experiencing a high psychological distress phenotype after surgery. So this tool really has the potential to serve as a point of care clinical decision support tool, helping clinicians to identify patients who may benefit from targeted preoperative behavioral health interventions. So in conclusion, this study highlights the utility of machine learning as a valuable approach for predicting high psychological distress following arthroplasty. The ElasticNet model demonstrated strong predictive performance with high specificity and fairly good calibration, making it ideal for integration into clinical workflows, and it provides strong transparency and interpretability. The ElasticNet model identified several modifiable predictors that could be sources of potential target through preoperative optimization strategies. And this study is the first to compare machine learning models to predict a high psychological distress phenotype after arthroplasty, which could advance risk stratification by really capturing the multidimensional nature of cognitive and behavioral characteristics. And the use of machine learning in this context allowed for the development of a Shiny app risk calculator with potential use for integration into clinical decision support tool. And we are currently finalizing this manuscript and planning to submit to the Journal of Arthroplasty. So this here is my wonderful committee, some funding I've received during my training and other collaborators and mentors that were really instrumental on these projects. And I thank them all very much for all of their support and guidance throughout my training. And that's all I've got. So I think we've got some time for questions.
Thank you, Michelle. I will try to facilitate us a little bit. That was fantastic. And there's some comments from Corey Simon. I'm looking to see Corey. Corey, if you're still on, I'd be glad for you to come on and highlight some things there if you'd like for Michelle to address.
No, not to address, just giving Michelle some things that we always struggle with
Yeah.
and hang us up, and maybe she can avoid some of our mistakes. So just throwing some things just consider. It's a different
Okay.
population, and when we think we have it, we find out, as you saw, that this doesn't always line up as it pertains to recovery, especially. So um, happy to put our heads together and help each other out with that because it's frustrating at times. There's something there for sure. My head goes to self-efficacy more than it does to, pain catastrophizing. Um, but I think it's not as distinct. I think there's a lot of bleeding on both sides of that model.
Yeah, Michelle, any follow-up to that? Any questions or comments?
Yeah, no, I think this is fantastic. I'd look forward to kind of discussing this further with Dr. Simon here and kind of sharing a lot about your group has done so much in this area, and it's so exciting just to continue to learn. And I think, the self-efficacy piece, I think you're right on it with that. I think that's a critical area that perhaps needs to be looked into quite a bit. And it was trying to think two, three. I mean, three out of the five for sure had three out of the five phenotypes that we characterize within this cohort had characteristics of the low self-efficacy group. So I think that's really key, and perhaps from a treatment perspective as well, it would be interesting to learn a little bit about the impact of interventions targeting self-efficacy and what that can actually do for patients post-operatively. So I think this is great, and I look forward to chatting a little bit more with you after that.
Awesome. Thanks, Michelle.
Yeah.
Question. This is a great presentation. Thank you so much. This might be a little half-baked, but so we know that people with more clinical indicated need for KR benefit more, so they have more pain and functioning pre-op. And I'm assuming that those people are probably less represented in that low distress group. And I'm wondering if you think that that machine learning model um, sort of adequately captured that interaction, or if you're seeing any sort of distribution by pre-op pain and functioning in that group.
Yeah, I mean, it was really interesting. We didn't, with the second study, we did not look specifically at the um, the pain interference and the physical function as deeply as we did with the first study. We kind of broke it down a little bit more with the first study. So, but we did find that it was one of the highest predictors for the high distress phenotype. We also didn't run, analysis to see, predicting low distress after surgery, which perhaps that would demonstrate different characteristics of different patient characteristics that would be classified as like the top predictors within those models. So it's hard to say, but yeah, I think definitely the physical function preoperatively and the pain scores it demonstrated really high performance on both on the random forest top 10 predictors pre-processing of the models, and then also post processing with the Shapley values. They both highlighted that. So that's something we can definitely look into, though, for sure.
Thank you.
Yeah, thanks, Maggie.
Other questions for Michelle? I'll ask one that's a little bit more pragmatic in flavor. And that is, do you know, are there places that are doing anything of this sort? And I don't necessarily mean like fine tuning of stratification, but any kind of risk assessment and doing something based on it. And I ask that because I'm always kind of thinking about, okay, what, what, how good can we do? How well, what can we predict? Or should we just, do something? Like we have some indication, at least, that some people are struggling, like, are going to struggle. And where do you see, like in your own research, maybe the juncture of those two, or what you're most interested in, or what you think is highest priority? You know, this line of clearly important stuff of trying to identify more fine-tuning identification of who's at risk and tailoring interventions versus where are we with even just doing the minimum, or maybe we're doing more than I'm thinking we do. So just from your clinical perspective and your research hat, like what do you think is going to be the most fruitful for us as a, you know, as a group of researchers in this area?
Yeah, that's such a good point. I mean, when I was turning, when I was thinking back to this, like as a clinician, right? Like, which is really what drove me into looking into these different phenotypes, was, does it really matter if I change or focus one intervention, psychologically informed intervention for one group, and don't provide it to another group? Are there differences with I didn't get into the treatment too specifically. I just provided an example of what that potentially could look like. But I think what we need to better understand is, how valuable are these stratifications within a clinic, right? So like, for instance, we know that low distress, okay, we know that group is distinctly different, and we know pretty much the pathway that we should send those patients on.
Mhm, mhm,
And the high distress as well, right? I mean, I think for those, it's pretty clear as a clinician, if you have a standard measure that you're collecting, as before a patient comes in, you kind of have a general idea, these types of patients, or this patient might present with these characteristics. But it's those three different groups in the middle that, does it really matter, right? Like, and even as we were looking at trying to um, conceptualize what our outcome will be with this, with the machine learning study, was, initially I wanted to try and predict a specific phenotype, but then that becomes really difficult, in terms of the methods and the complexity of the models themselves. Does it matter if we predict low self-efficacy and pain coping, or does it matter if we predict the low distress group? Is really challenging. So we decided just to do the high distress group because we felt like that was the prediction that would give us the biggest bang for our buck. But there is also, with our first study, we found that patients within that low self-efficacy and poor pain coping, that group had really high, frequency of transitioning to high distress compared
mhm,
to the other groups. So it's hard to say, if we combine maybe those two groups as being the most valuable from a clinical perspective of making sure we can identify at least those two groups,
mhm.
and send them down a different care pathway. Perhaps that would help. But for the purposes of my dissertation in this study, we just isolated high distress by itself. But that's something in the future, be able to predict, do we combine certain groups? Um, Dr. Lenz has shared with me too in the past, would it be more meaningful just to do like a low, moderate, high distress group versus the five different phenotypes that we found? So you bring up a
Mhm.
great point. And clinically, sometimes the hardest thing is just collecting these measures
Mhm.
themselves. And sometimes, depending on what health system you're at or what clinic and what process you have, sometimes just having good collection rates is
Mhm.
enough. And if you're already there, if you're already achieving 80% collection rates, then perhaps you can move on to things like this, where you can develop some type of, clinical decision support tool within the EHR that can help clinicians. But yeah, you bring up a great point, from a pragmatic clinical perspective. Absolutely.
Yeah, and that's great. And I appreciate your kind of your one of the things you highlighted about groups that maybe, you know, that kind of low self-efficacy, poor pain coping at pre-surgery are probably not people that would pick up with traditional measurement or just even observation, right? That might not be
Mhm.
obvious, but that because you've looked at this longitudinally and you see that they do end up with some, you know, some worse outcomes. And yeah, so I think that's particularly interesting.
Yeah, and in that specific group, the low self-efficacy and poor pain coping, they don't present with, high depression or with anxiety, which is what you usually see collected in most
Mhm.
clinics. So if you're not, stratifying by some more of these, kind of on like the kinesiophobia, the pain catastrophizing, the fear avoidance, if you're not stratifying by those different characteristics, that group may seem as a low distress group when in reality, they actually have a higher tendency to transition to high distress after surgery. So that's a great point as well, is the value of really looking at this from a granular perspective is really important.
Other questions, comments? Let's see other things in the chat. Michelle, any other things you want to ask or bring up? Any questions for this group? No pressure. You don't have to. That was not part of our ask for you, but you have people here who.
Yeah, no, I think this is really exciting. I mean, I would love to chat more with others who are doing similar work or have maybe potentially even um, used machine learning methods to try and predict some of these type of behavioral and cognitive characteristics. I couldn't, when I was doing my literature search and going through that process, it was really hard to find that. And so it makes me wonder, maybe others have done it, but they haven't had good success or they don't find it clinically meaningful. And just to gather more thoughts on why that might be, or other ways that we could do this better and make it clinically applicable. So if anyone wants to chat further, I'd feel free to shoot me an email or we can connect for sure.
All right, well, if there are no other comments or questions, we'll close here. Thanks again, Michelle. That was really fantastic, and
Appreciate it.
look forward to hearing more from you.
Yeah, great. Thank you so much for having me. Thanks, everybody.